bit of a completely different topic here. Diagnostic testing and research. So again, as medical professionals, at some point in your career, you've learned about diagnostic tests, but I don't know if you realize how pervasive diagnostic tests are, even in medical research. You know, because diagnostic tests are absolutely everywhere. They aren't just your laboratory and radiological examinations, but indeed, they are the elements of the physical examination, right, are diagnostic tests. They have a certain sensitivity and specificity. The questions you ask patients have a sensitivity and a specificity, perhaps in part explaining the attending effect, right? The order you ask the questions has a sensitivity and specificity. The standard p-value, as I'm going to show you, and its cutoff create a diagnostic test. So understanding diagnostic tests is really important, obviously, for patient care. We already know that, but it's important for medical research and interpreting the medical literature because p-values are everywhere. So what's a diagnostic test? It's a tool that helps you make a decision, generally about whether a patient has a disease or not, right? But as I've already said, it's broader than that. And each test has characteristics that make it effective or ineffective for its task. So the primary characteristics of a test are called its accuracy and precision. You recall that accuracy is how well the test corresponds to the true value of what it's designed to measure. That's usually determined by a gold standard, right? Does this thing actually accurately measure CSF sodium? The precision is the reproducibility. If I take the same sample and I look at it again and again, do I get the same answer? So reproducibility, that's what precision is about. And that's monitored with a control sample versus a reference standard. So this would be accurate but imprecise, right? This would be precise but inaccurate because it's all clustered together. Again, this is all relative, okay? And this would be what you really want, all the arrows hitting right on the target, accurate and precise. But accuracy and precision are only about the inherent quality of what the test does, that it says it does. It has nothing to do with it. Well, it has something to do with it. It's not a good test for what it is. It's not going to work. But it has nothing to really do with its diagnostic capabilities, right? Because you could have a 100% accurate and precise test that measures exactly every time what it's supposed to do, but it's useless as a diagnostic test, just like the CSF sodium I just brought up. I don't think that'd be a very good test for whether you have multiple sclerosis or not, even if I had the perfect CSF sodium measuring device, right? So what is we get at when we want to know that part of it? Does this test work for the disease that we're talking about? Well, that's where the sensitivity and specificity come in. And these are the diagnostic characteristics of the test rather than the primary characteristics of the test. And I think I know how hard it is for me to remember these things. And mnemonics never really worked for me. Is it spin and snout and spout and spin and what is it? I don't know. Okay, now you're probably confused if you knew. So I just like to think about these two things in a parallel way, okay? Sensitivity is the proportion of diseased people correctly identified as being diseased. And specificity is the proportion of disease-free people correctly identified as being disease-free. Now that doesn't mean you can keep the labels right up above, but at least it's a very parallel thing. At least you know if you're doing one of these two things, you either have the sensitivity or specificity. And I think if you just this is a case where they really are, opposite, right? In the sense of like thinking not about positive and negative, although the P and N are sort of there, right? But about disease, and you sort of think of just disease as about, because again, it's about the real world. Does this person have disease or not disease? If you remember that, you remember this parallel part, and you remember that, the P is the people with disease, right? They're positive, sort of, right? If you had a perfect test, and then it's the opposite, right? So it's kind of complicated, but as long as you remember this parallel piece, diseased people correctly as diseased and disease-free as being disease-free, you're a lot further along, probably. So again, if we're going to do the sensitivity, that would be the diseased people correctly identified as being diseased. So here's that nasty 2x2 table again. Sorry, bringing back horrors for some of you. It is Halloween week. So again, the people correctly identified as having disease amongst the people who are diseased. So that would be this number. These two cells added up on the bottom with the disease on top. Likewise, the specificity is the opposite of that. It's the people who really are disease-free, correctly identified as disease-free. So it's this divided by the sum of those two things. Again, I've already mentioned, this is a little confusing, a little non-intuitive, because also there's this thing, right, that specificity is about the people who are truly negative, with truly negative tests among patients without disease, but when specificity is high, it indicates the test is most useful when the test is positive. This is where people are like, it's hard. Because a positive test, right, from a highly specific test is a strong indicator that a patient has the disease. Acetylcholine receptor, from my field, acetylcholine receptor antibodies for myasthenia gravis. If you have those antibodies, you have myasthenia gravis. You may not be manifesting any symptoms right now, but you have myasthenia gravis. Here are the mnemonics. They work for you. Great. I think I can usually remember this one. And again, then you remember that parallel piece, it helps you. This one is a little bit, again, spouts, spins, whatever. All right. So why is this so hard for us, right? Well, it has to do with conditional probability. So we're really prone to logical errors and miscalculations when we use probabilistic tools, of which diagnostic tests are one. So we like heuristics. That's the way we're built as people. This is, a source of stereotypes and all kinds of biases and the bias of the other kind, that we have, rather than using algorithms, rather than using the actual formulas that underlie those probabilities. And conditional probability is an area where we are particularly prone to failure. I mean, this question. If I flip a fair coin 10 times, gotten head each time, what's the probability I'll flip heads on the 11th flip? The answer is B. The answer is B. It's been drilled into you in school. It's B, but you don't feel that way. Be honest. It hurts when you put B down. It doesn't feel true. And that's natural, and that's why this is so hard, right? We don't want to answer that. This is the game show question. Who wants to make a deal or something like that, right? So you're on the game show, and you're given a choice of 3 doors. Behind one door is a car, behind the other goats. You pick door number 1, and the host, who knows what's behind the doors, opens another door, say number 3, which has a goat. He then asks you, do you want to switch your choice? It sounds like you would never want to switch your choice, but it turns out you're better at winning if you do, because of the conditional probability, because he's revealed some information. And this doesn't make any sense at all. Like, how did that change? I already made my choices. That it does. You can read about it on Wikipedia or something. And see if you can convince yourself that it's true, because it's very non-intuitive, okay? Or this XKCD cartoon, it goes, the lightning's cracking around them. Whoa, we should get inside. It's okay. Lightning only kills about 45 Americans a year, so the chances of dying are only 1 in 7 million. Let's go on. And of course, the punchline is that the annual death rate among people who know that statistic is 1 in 6. Because what do? Because they stay out while the lightning's out there saying, it's not a very big risk. That's conditional probability. Well, that's a funny example. This is not such a funny example. This is Sally Clark. So Sally Clark sent to prison for double infanticide based on the following physician testimony that the probability of SIDS was 1 in 8,500, and therefore the probability of having 2 babies die of SIDS, you just multiply those together, and that's 1 in 75 million. And therefore, it's unlikely she's innocent. What's the problem with this? When can you multiply probabilities together? Like this. So you only do it when the probabilities are independent of one another, right? Are the probabilities of a mom having 2 babies with SID independent of one another? No. Because we all know, right, that there's shared genetic and environmental risk factors for SIDS, right? So that's a huge error right off the bat. But there's another subtle error here, and it gets back to diagnostic testing. So I want to walk you through it. So even if you could assume independence, this other error would still be there. So let's expose it with an example. You just won Powerball. Okay? Well, you must have cheated, right? Because you only had like a 1 in 200 million chance of winning Powerball, if you were being honest. So I know you didn't really win Powerball. So the chances of telling the truth given you won are similarly small, right? No, that's not true. And that's because of this reversal here. It's the fundamental reversal of medical school in the traditional curriculum, right? And I'll explain what I mean by that in a second. But the probability of A given B does not equal the probability of B given A. So we're in medical school, right? And so the first few years, we're reading our books and we learn, oh, okay, when you have pneumonia, you have a cough and a fever. And if you have lymphoma, you have these symptoms. And then you get to the clinic. And the patient comes in with a cough and a fever. Do they have pneumonia? Not necessarily, right? Because you flip that thing. Or they just have a fever. Do they have pneumonia? No, because the whole thing's been flipped around. You're now like in this whole other probability world. And it's much harder. It's just a totally different world, right? It's easy to go from that to this, but not the other way around. And our brain starts to think it's the same, and it's not. And we've already talked about Bayes' theorem today. And I'm going to go through this in detail, but that's Bayes' theorem. And the reason we do this is because we usually don't have all these numbers, and even if we did, maybe we don't like math. And we get away with it a lot because sometimes they're pretty close, but a lot of times the difference is substantial, so we have to be careful. So let's walk through this with this Sally Clark example. So these letters mean certain events are happening, and then the probability of them, and then the line tells you that the probability of something given something else. Okay, so A given B. That's what the line means. And this is B given A. So let's define the events. A is innocence, B is 2 babies dying. So the probability of B given A is the probability of 2 babies dying given she's innocent, right? Because that's B, 2 babies dying given she's innocent. That is a tiny probability. I'll admit that. Probably pretty tiny. But P of B is the risk of just having 2 babies die, independent of whether you are innocent or not. And that's also tiny, right? And so P, B given A and PB are about equal. And what happens when you divide 2 numbers that are about equal? You get 1. So we cancel them out. And so if we do that, we find that the probability of A given B is approximately the probability of A, which means that the probability of her innocence given she had 2 babies die is about equal to our prior estimate of her innocence. In other words, we need more information. We haven't learned anything by the fact that she had 2 babies die. It's essentially irrelevant. We would need other evidence in order to convict her. And this is called the base rate fallacy. It's the failure to account for the base frequency of the event. This is also called the prosecutor's fallacy. The failure to account for this very reason, failure to account for the frequency of the event that brought the accused into the courtroom. If you're talking about theft and you have somebody come in and you've caught them red-handed, okay, that's a common event, all right? That's okay. This works a lot of times. But when you start getting to rare stuff, you're failing to account for the fact that this is so rare, that this is a rare thing to happen to begin with. And then when you work all the math, you can see that it's just going to turn out to be pretty small. So we have to flip that conditional, right? So when we're seeing a patient, and we did this in our case control study, right? When we see a patient, we want to know the patient's probability of disease given their test result. But what we have is the probability of a test result given our patient has a certain disease state. That's sensitivity and specificity, right? Because it's about, that's the probability that they will be correctly identified as being diseased when they are diseased or vice versa. That's the probability of a test result given the disease. But we want to know the opposite thing. What's the probability that they have disease given the test results? So how we flip it, Bayes' theorem, right? This is the thing that lets us convert this into this. And you've been through some of this before, but it's worth reminding ourselves how it works. To do Bayes and to do this diagnostic test thing, you need three numbers. You need your opinion, the test characteristics, and then you'll get the answer, the third number. So one of the things I've given this talk to like a national conference, and you know that guy gets up that you hate seeing when they come up to the mic because you know that they have nothing nice to say about what you were talking about. It's like, I take issue with you saying it's our opinion. Like, okay, well, I hope your opinion is better than the guy on the street. But at the end of the day, right, this number of like how certain you are the patient has disease or not is based on the questions you ask, how good you are as a physician at asking this question, all the sensitivities and specificities that you've already put into this, all go back in the end and create something like we call our opinion, right? It's not bad that's your opinion. I mean, I hope your opinion's based on evidence, right? It doesn't change, though, that at the end of the day, it's like what you think. And what you think has a big influence on it, probably bigger than we often think, right? Anyway, so here's an example again from NeuroOp. C-reactive protein in giant cell arrays. So 62-year-old man comes to the clinic with anterior ischemic optic neuropathy, which is the blinding condition of GCA. You know GCA can blind you, and then you got to treat it with steroids really quick if you want to keep the other eye from not going blind in many cases. So it has a little bit of a headache, but it also has hypertension and a small cup to disc ratio in the other eye, which are risk factors for a non-arteritic form of this, which is the more common form than GCA. Have no other features of giant cell array. So what's my opinion in this case? I purposely made it kind of borderline. I don't know, about 50-50. I don't really know. So I formalize that opinion based on a pretest probability. And I assign a value from 0, no chance, to 1, certain for how likely you think it, and then I convert that to an odds. And we've already talked about that, so I'm not going to dwell on this again. Okay, like take that probability, 50-50 though, right? Okay, how many with it? One person with it would mean there's one person without it. That'd be 50-50, so that's an odds of 1. And there you go, pretest odds of 1. So you can do this in your head if you start practicing. It's not terrible. And here's the C-reactive proteins sensitivity and specificity. So what's the probability that the test is positive given the patient has GCA? We know the answer. It's on the screen. It's sensitivity. Positive in disease. Okay? But that's not the question, right? The question is, does the patient have GCA given their CRP has a certain value that's positive? So what's that probability? It all depends on the pretest probability of GCA, just as the Sally Clark case hinged on the prior probability of innocence and the test result, so which is the new evidence we have, right? So what's the likelihood? Well, a likelihood is the probability of data you observe given an underlying truth. The data you observe given a truth. So in diagnostic testing, the data is the test result, right? And the truth is whether the patient has disease or not. And therefore, sensitivity, being the probability of a positive test given disease, is a likelihood. So you've heard likelihood ratio before. And what you do is you have two kinds, right? Whether the test is positive or whether the test is negative. And again, due to like flipping these probabilities, you can work out these things, but these are the right numbers for these things, right? Because of this is positive in disease, so the flip side, negative in disease would be 1 minus that number. So if you sit down, you kind of scribble out this tree, and this is the way you're thinking about it. Okay, test result, what am I going to? You'll get this. And then it turns out you just need to like look at the right branch of the tree and divide those things the right way with the person's disease state on top. Okay, so that's the likelihood ratio negative, and that's the likelihood ratio positive. because it's a ratio of likelihoods. We just said the sensitivity is a likelihood, the specificity is a likelihood, 1 minus them is still a likelihood, and we're dividing 2 of them into likelihood ratios. And this is how you get the right ones pretty quick. So let's assume the test is positive, sensitivity 0.95, specificity 0.8. What's the likelihood ratio positive? Those numbers 0.975 divided by 0.2, 4.875. I multiply that by my pretest odds, right? And lo and behold, I get the same post-test odds as the likelihood ratio because it was a 50-50 coin flip thing to begin with. And now I can take that odds in my head. Okay, I have an odds of 5. That would be 5 over 1, which would be 5/6 when I convert to probability. That's pretty high probability. I don't really need to do the math, right? That doesn't sound good. But it's 83%. I better start some steroids, right? If the CRP was not elevated, then the post-test probability would have been 3% in our example, if you go back and do the math. So the test was super helpful in this case. However, if we are certain one way or another already, the test doesn't help us. If I'm already convinced that you have disease, and then I run the test and it's positive, I'm still convinced you have disease. And if I'm wholly convinced and I run through the math and it's negative, you still have a 76% probability of having disease. I would still treat you. Okay, so like it's not as helpful when your mind is made up. So this is very intuitive too, right? And that's where Bayesian statistics are very intuitive because it has to do already with what the prior evidence is and what the prior thinking is, and the state of that. And you have new evidence. How should I weigh this new evidence in light of what I already knew? If my mind's made up, the new study doesn't tell me anything, right? If I'm already convinced that ivermectin, helps you with COVID, I'm not gonna sway you anything with some test, some study, positive or negative, right? Well, probably positive, you'll go on and tweet about it, but whatever. So even if you only had 3 individuals in your randomized controlled trial, okay? So receiver operating characteristic curves are another thing in this process. So likelihood ratio emphasizes the relative and the importance of the relative balance of sensitivity and specificity. And many tests produce continuous output, CRP being one of them, right? But you have to make a decision. So you want to categorize your decision. So you say yes or no to something, and that's how you can do this with a continuous value. And ROC curves capture that relationship. And you can also calculate the area under the curve, which is also called a C statistic. And that's a measure of the test discrimination ability, which is the probability that randomly selected pairs of diseased and non-diseased are correctly differentiated. That if I get a random diseased person and a non-diseased person, and I run the test on them, and I say that one's diseased and that one's non-diseased, that's the probability that will happen, that area under the curve. And this is the line that represents a coin flip. You're not sure with a certain test. And if it went all the way over here and like that area of the curve was 100%, because it's the whole box now, because the curve's all the way up in the corner, that would be a perfect test, okay? And what happens is that this is sensitivity plotted by 1 minus specificity. And so the key to understanding this is I can always create 100% sensitive or specific test. I just can't do, here's my new company, 100% sensitive tests, 1-800 sensitive tests. You call me up. Does my patient have disease? Yes. Call me up. Does your patient have disease? Yes. I don't even need to stay on the phone. I have my whole recording. Yes. Yes. When you stop talking, yes. That's a 100% sensitive test, right? I'll find every case of disease, and vice versa. You're my competitor now, and you're like, hey, he's got a great idea. I'm going to give you the 100% specific test. Yeah. No. Okay. So that's what this curve is getting at. Well, that's why the corners are pinned here. And the question is, do you want a stricter threshold or a more moderate threshold? This is you saying the CRP has got to be really high before I believe it. And this is like, it could be like just borderline and I'll start believing it. And that's where you move along this curve. And usually we try to pick thresholds that sort of balance sensitivity and specificity for the reasons I just said. But right, there are reasons to go one way or the other. On a screening physical examination, My goal is to have a very sensitive test most of the time. As a neurologist, the one I don't want is the sensory exam. I just go like, does that feel different? Does that feel different? Okay, like, oh, no, good, thank you. Does that sound different? Like really quick, I just like, did that sound different? Okay, don't belabor that one because I want that one to be more specific because it drives me crazy. Like, it's about 95% on that side and 99%. So we all work on this curve all the time, even with just the things we do in the clinic, okay? Okay, now I want to get into a little bit of the research aspect of this in the last, 10 minutes. So some of you will hopefully be studying diagnostic tests. You're trying to develop a new diagnostic. And so there's several things you need to know. And if you're not, that's fine. You also need to be able to evaluate the medical literature about this. So when you're looking at a new diagnostic test, there's several questions to answer. One, is this test useful for the clinical scenario that the researchers studied? Is there actually a diagnostic dilemma? Back to what we just said. If there's no diagnostic dilemma, you already have your mind made up, right? So the test isn't going to help you. Is the clinical scenario useful to your practice? Same kind of problem, but something we call spectrum bias. It's like it applies, it's a good test, but it doesn't work for me because I see the sickest patients all the time. Was an appropriate gold or reference standard used? And was it used regardless of the test results? So of course we try to avoid the costly, gold standard most of the time, especially if it's like, autopsy. That's a good one to avoid. That's great in medical practice, but it's not good when you're doing a new diagnostic test. You have to go all the way out to find out what really happened under the gold standard in both the people who had a positive test and those who had a negative test. Otherwise, you're subject to something called verification bias. Are the people interpreting the test and those interpreting the reference standard blinded? Right, again, back to some just basic principles. Are the test characteristics adequate for my need? So likelihood ratios greater than 10 and less than 0.1 are typically considered ideal. If you're between that 0.5 to 2 sort of likelihood ratios, those are considered not as helpful. We'll see where a p-value falls in a second, okay? And then, of course, the question, how will the test change how I diagnose or manage my patient? Back in the CRP example, it's still worth doing the test because later when I put that patient on steroids and they break their hip, people are going to ask me, well, how likely was it really that the patient had it? Was it 76% or 99%? Because now we're kind of like wondering, and the patient seems to have gotten, kind of better. Should they stay on the steroids? That kind of stuff. So there still can be reasons beyond the diagnostic reasons to do that. So you know that, but it's worth saying in case somebody reads me a different way. Okay, so there's also screening research. Maybe you're working on a new screening test. So the key question is, does early detection improve prognosis? So to be suitable for screening, the disease must be detectable in the preclinical phase, and that early treatment should convey benefit over treatment at the time when the disease would have come to attention without screening. I'd like to thank also Mitch Klein for some of this stuff. He's one of my favorite Ron's professors. Big reason I'm an epidemiologist today. He's retired now, but hopefully enjoying his time in Amelia Island. So biases in screening research. So there are three main ones: prognostic. They call it prognostic selection bias. It's confounding in my opinion, but that doesn't really matter. Lead time bias and link-based sampling. Prognostic bias. So those who volunteer to get screened, like volunteers often are different in the ways that people who don't volunteer to get screened, right? The people who go get their colonoscopy are different than people who don't. Some of those differences may be related to the outcome. Well, I kind of like not feeling this, kind of tired. Maybe I'm anemic. Maybe I should go get my colonoscopy. And so since these unknown factors among volunteers likely cause their exposures and disease, I think it's better called confounding, my opinion. Lead time bias. Screening leads to earlier diagnosis, right? That's what screening does. But therefore, the screening can appear to lengthen the survival time from diagnosis, even if it has no effect. Because the difference in time between the date of diagnosis with screening and the date of diagnosis without screening, that's the lead time. That extra time can explain all the association by why this group did better than the other group. So for example, George and Tom die exactly 5 years after getting colon cancer. But George was diagnosed 1 year earlier than Tom. So George survived 1 year longer than Tom after diagnosis, but not after disease. So really the screening did not help him. He had 1 year of lead time. That's all. Maybe you don't want to know, right? There's the downsides to being diagnosed. Length-based sampling. There's natural variation in the rate of disease progression. Some are fast, some are slow. Slow progressing cases have a better prognosis, right, usually, than fast, on average, than fast progressing cases with or without screening. And disease duration for slow progressing cases is obviously longer than the fast cases, so therefore, they are more likely to get screened, right? Because they have more time to get screened than the people who are going to go downhill immediately. And that larger proportion of slow progressing cases that are likely to be screened will make it appear that the screening benefits, even though it has no effect on survival. So again, if you're doing this stuff, you need an epidemiologist, right? There's a ton of stuff you can do wrong and get the wrong answer because of these biases. And I'm sure these are not the only ones. These are just the primary ones. Okay, last thing. Statistical tests are diagnostic tests. Of all the clinical trials performed, what percentage do you think are for truly effective treatments? Of all the clinical trials ever been done, what do you think? What's your pretest probability? Next clinical trial you do, what do you think? What's the chances it's going to work? I said 10%. That might be high. You might think it's low. You can plug your own number in a few minutes. That's a 1 to 9 odds, right? You have 1 person with it and 9 people without it. So a type 1 error rate of 0.05 and a type 2 error rate of 20%. You've heard those numbers before, right? It sounds familiar. That's your p-value threshold and your power. That's equivalent to 95% specificity and 80% sensitivity. That's exactly what that is. So the likelihood ratio positive is 16. Hey, what did I say? More than 10? Pretty good, right? This is not a terrible test, okay? Not a terrible test, even though there's lots of criticism of p-values, and I have plenty of them. But I won't share those with you today. Or if you want to talk about it over lunch a little bit, I will. So anyway, I take that 1/9, multiply by 16, get 16/9, and my post-test probability is 16 over 25. That means that among statistically significant trials, 16 of 25 are for truly efficacious treatments. Of course, that means that 36%, 9 of 25 of the treatments with trials with significant results do not work, okay? If that's the threshold you're using, okay? No wonder we have replication problems and people saying that things don't work, okay? That's why people are talking about tightening these things up, doing other things. This alone can be a significant issue with our science. The Sally Clark case didn't turn out so well. She did get out of prison ultimately. It turned out that there had been other women put in jail in England and the UK for the same thing. And she never got over the psychological trauma, and she was found dead from acute alcohol poisoning a few years later. Now, I will admit, there were some, diary entries and some other things. There may have been some other evidence in this case, but again, it was said in the inquiry that testimony was what had influenced the jury primarily. So a firm understanding of probability and diagnostic testing is important for us. Yeah, you can kill patients in different ways. They killed Sally Clark, let's say, okay, by giving bad math as a doctor. So it's really important for us to carry out our role as experts, both in the public forum and in our most private patient interactions. So with that, I'll stop. And I think we might have a 30 seconds, a minute or two for questions. And of course, I'm going to stay around for a few minutes, and I'm happy to talk to people, as we're talking, eating, whatever. Anything? Yes. Well, yeah, I mean, you would need to, if you have in the absence of any other information, yeah, you would use the prevalence of disease, I guess, in that population. Yes, it would matter how well that, to go to that stage, right? In the absence of any other information, that would be your pretest probability. And yes, it would matter what it is for your clinic. And then you add on top of that, right, the other things when you do your exam, your history and your physical, to tweak that probability based from that baseline prevalence, and then you go run the test. So yes, you should account for all that stuff, all the stuff before, and now you're just adding this little piece of data, if you can. It's not easy, right? And that's why there's a lot of art to medicine. Yes. Mhm. It depends, which is what we say all the time. Yeah, I mean, I think that like this diagnostic test stuff, in terms of the research types of stuff, are pretty well understood. Particularly like if you are doing screening research or pharmacoepi type stuff, there are many well-known issues. I don't want to be too biased towards, doctoral epidemiologists, but we do get, there's a reason you get a PhD, right? I mean, so like an MPH gets a lot of training, they do, but I can tell you from my own personal experience being in the MSCR program, which has basically the epi components of that, and then doing my PhD where I had to get the rest of the master's courses. This didn't really get in my bones, this stuff, until I did my doctoral degree. Like I didn't, case control studies and being able to like come up here and like be willing to claim that men could be the, that didn't get into my bones until I did my doctoral degree. So I think you do want to find, just like anything else, you want an expert, right? You want somebody you can trust. So you might want to do your research. You might want to be sure that this person is well known in their field and all this. You may not be able to choose that, right? But just like you would picking a doctor, that's how I'd want to choose my epidemiologist, right? How do they publish? Do people like them? Do they know what they're talking about? Do they deal with this specific issue? Are they a screening researcher? And then I don't think you'll get as many different answers. Yeah, we're not all the same either in our epi qualities. But there is haziness, a lot of, because of back. This kind of close the loop on that. There is some haziness because many of the things that we're talking about are in the theoretical world, and that's why you're important. Your subject matter knowledge, and I think it's sometimes I can say from my personal experience that having the medical background and having the epidemiology background is a huge help because you can talk to both people, right? But and you know what this person is really trying to say and what that person is really trying to say, and you can help them understand one another. And I encourage you guys that if you're interested, to pursue additional epi training and other things, it will make your research a lot better. And again, I think that's the course that a lot of people take now. If they're interested in being clinician scientists, they at least get that basic part. And there's a lot to learn. So I'd encourage you to do that. Thanks.